Friends, supracondylar nailing for distal femur, both supracondylar comminuted as well as intra-articular comminuted fracture is a very good modality of treatment for such fractures. With the availability of multi-lock supracondylar nailing, we are able to tackle much more complicated cases also by this technique. In this presentation, I would like to share some of the cases done in the last 20 years by supracondylar nailing and in the recent past done with multi-lock nailing. I will be also sharing the video or the operative video of a multi-lock supracondylar nailing case, and will be also sharing some tips and tricks to avoid complication. Hope you enjoy this presentation. Friends, in this talk I will be talking about why I prefer supracondylar nailing for distal femoral fractures. A case done by me only. There is enough of literature available which talks about there will be no alteration in the patellofemoral joint if inserted properly. The biomechanics of patellofemoral joint is not significantly influenced by supracondylar nailing. No knee problems in more than 57 cases with retrograde femoral nailing. If the antegrade nailing is difficult, then retrograde nailing is justified. This is very useful in bilateral femoral shaft fractures, especially in obese patients, or as in this case, the patient had splenic injury which the surgeon tackled from the top. Meanwhile, supracondylar nailing for the femur was carried out. Why I like supracondylar nailing? We all know that the distal femur is bell-shaped, and for antegrade nailing, isthmus will be the limiting factor. Inventory required for an antegrade nailing is much more. One should have all the exact size nail and exact thickness nail available. Reduction of supracondylar femur fracture, I feel it's much more easier over a bolster rather than over in a orthopedic table where recurvatum is very common. Locking plate which has come in the market in the last 15 years is not a panacea, especially if there is medial comminution, and the quality of the callus seed is also not that great. We all know that intramedullary implants are biomechanically much more stronger as they are load sharing implant, unlike plates which are load bearing implants. This supracondylar nailing is very useful for periprosthetic fracture, segmental fracture, floating knee, bilateral fractures, obese patients, fracture neck with fracture shaft, etc. Once interlocking became much more popular in the early 90s, we started using it for extended indications like metaphyseal region fractures like supracondylar fractures. In few cases, we could get away with antegrade nailing, but majority of them had some other problem because of the thin nail due to isthmus, which was the limiting factor. An article by Dr. Sunil Kulkarni about antegrade nailing for such fracture is beautifully demonstrated few representative cases. A badly comminuted supracondylar fracture with good clinical outcome, though the patient had subtle recurvatum deformity. Another double segmental fracture of the femur, beautifully executed with antegrade femoral nailing, and the function. But we can see that for such distal femoral fracture, the isthmus becomes the limiting factor. One cannot insert a nail what isthmus cannot accommodate. And also in the distal femur, multilocking is essential. If you don't have the exact size nail, it is possible that the locking holes might come at the fracture site, becoming a stress riser. As you can see in this example. The problem with antegrade femoral nailing is the distal femur is bell-shaped. The wide medullary canal, the nail can occupy a large area either medially or laterally in this fashion. We all know that the cross section of the femur, the canal is wider distally, and as you go upwards, it is narrower. So the supracondylar nail also matches the at the insertion. It's 13 millimeter, and as you go proximally, it is 12, 11, and 10 millimeter different thickness nails are available. A segmental fracture, subtrochanteric with supracondylar fracture. The problem with this supracondylar fracture when we operate on recurvatum deformity, as you can see here. So when I was operating this patient also, the guide wire, as you can see that there is recurvatum deformity. This I could tackle by exchanging the beaded guide wire with a simple guide wire, and nail was passed, and through the nail the guide wire was passed again into the place which was better position, giving good reduction to the fracture. This is the immediate post-operative X-ray. These are some follow-up X-rays in the same patient. These supracondylar fractures get beautifully reduced with a small triangular pillow or a bump under the distal femur, and this recurvatum gets automatically corrected with this bump. These are pictures for AP and lateral of the C-arm for the distal femur. A intertrochanteric fracture with supracondylar fracture, treated with keyhole surgeries for both, and the clinical picture, and the immediate post-operative X-ray in the same patient. Little complicated case, supracondylar comminuted fracture with intra-articular extension. I have reduced the intra-articular element with a cancellous screw holding percutaneously with bone clamp, and then carried out the supracondylar nailing. This is the clinical function in this elderly man at 6 weeks, and this is the clinical function at 4 years when the patient came for implant removal. Another badly comminuted supracondylar fracture with fracture patella and HOFA element, again treated by putting back all the fragments around the nail. Clinical picture at 4 months follow-up, patient able to squat. This is at 9 months, the fracture consolidated. These are after 2.5 years when the patient had come for implant removal. Another badly comminuted supracondylar fracture with intra-articular extension, C3 type of fracture, treated with putting back all the fragment by open reduction around the nail. Immediate postoperative picture. Picture at 4 months showing 80 to 90 degree of knee flexion and subsequent knee function. These are the pictures after 4 years after the implants have been removed. Patient had a reasonable function of about 100 degrees of knee flexion. Friends, why I am showing this C3 type of fractures where nailing is contraindicated? This supracondylar nail is more indicated for simple supracondylar fractures or at the most little comminuted in the supracondylar region or plain intra-articular extension like C1 type of fractures. But why I am showing all the C3 type of fractures? I feel that these implants are good even for C3 type of fractures. As you can see, the excellent outcome in all these cases which I have been showing. Another badly comminuted C3 type of fracture, a compound fracture to begin with. The fragments were so small that I had to use K-wires instead of screws to fix them around the nail. This patient had a quadriceps stuck up, and after we did the quadriceps plasty, the knee function improved to almost 90 degrees of flexion. Another supracondylar fracture with HOFA fracture. This is picture as soon as the fracture was opened. The same was fixed again with a supracondylar nail with interfragmentary screws. The alignment, if you see, is the distal fragment is beautifully aligned to the proximal fragment, and the knee alignment is also good in spite of medial bone loss. And this is after the fracture consolidated without any problem. Probably if I had used a plate here, due to the medial bone loss, the plate would have bent or broken. For the last 15 years, we have anatomical distal femoral locking plates available. They do excellently well if all the principles are followed well and if there is less comminution medially. If there is medial comminution or medial bone loss, which is very common in these type of fractures, then this may not give a good result. Bending of the plate and breaking of the plate are very, very common. Hence, such bad comminuted fractures, double plating is advocated. Another example of comminuted fracture, good result with double plating. Another badly comminuted fracture treated with double plating. Friends, why I don't like plating? It's not that I don't do plate. I have done enough number of plates to have my own experience. But I feel that nailing is a better option and not the plate. My views are supported by the study by Henderson in 2009, where he says that the plate gave rigid fixation. At 3 months, there is hardly any callus seen, or there is 0 mm callus seen at 3 months at the fracture site, whereas with a nail, you can see that 330 mm³ of callus is seen. This is due to the micro motion which this nail allows, unlike the plate which gives static fixation in absolute rigidity mode. Nailing is a good option for distal femoral fracture, but unfortunately the size of the nail can cause the fracture to go into non-union. Hence, you can rest the movement of the distal nail in the distal femur by putting blocking screws to get good amount of good callus. These are the two blocking screws which can be inserted to restrict the unwanted movement of the nail. Nowadays, with the availability of multi-lock supracondylar nail, this multi-lock, the oblique locking available itself can prevent the movement of the nail, and this gives much more rigid fixation for the nail in the distal fragment. That is the reason why I am again back to multi-lock supracondylar nailing in the recent few years after trying plating in between for few years. This nail, especially if treated with dynamic locking, can give axial micro motion like Elizero, producing abundant callus. The earlier supracondylar nail available in the market had just lateromedial locking, and there were simple locking boards and no compression screws for intercondylar element was available. But the newer nails available nowadays in the market, there are 4 or 5 distal locking, multi-locking available. 2 or 3 of them are lateromedial and 2 of them are oblique. There are locking bolts, means the locking bolts get locked within the nail. Bicompression screws can be used to compress intra-articular fractures. This is how the earlier nail and the newer nail looks. The newer nails come in longer form, that is 25, 32, 36, etc. Earlier to this newer locking multi-lock nailing, simple multi-lock nails were also available, where simple screws could be passed in the distal fragment at oblique angle. This is the most recent nail which I am using nowadays for the last 2 years. The distal locking, the locking bolts have got threads, and the nails also have got threads within the locking holes. So these locking bolts get locked within the nail, preventing unwanted side to side movement of this nail. This is an example of supracondylar comminuted fracture with condylar fracture of the tibia. We would restrict to only the femoral part, comminuted supracondylar. I treated this with multi-lock supracondylar nailing. These are the different stages of intraoperative pictures: guide wire position, enlarging the entry site, passing the guide wire across the fracture site, enlarging the entry site in the distal femoral condylar, reaming with simple hand reamers, passing the nail and locking, as there was comminution in the supracondylar region. To achieve the length, I have used a plate as an augmentation plate with the nail, and incidentally I was able to get one of the locking bolts of the proximal plate through the nail, which is called as rendezvous technique. This is immediate post-operative picture on the table. Keep all these supracondylar patients on a knee frame with 90-degree knee flexion. So getting knee extension is not a problem, but if you keep the leg extended, getting knee flexion is a problem. Hence, I prefer to keep them on a knee frame in this fashion in the immediate post-operative period. This is the immediate post-operative picture. 2 months follow-up picture. 4 months follow-up picture when the patient had excellent clinical outcome already. This is at 7 months when the patient had come last time for follow-up. You can see that the patient is able to squat as well as stand single stance on the operated femur. This video shows the patient walking comfortably on the right lower limb, which has been treated with the augmentation supracondylar nailing with plate. On the left, he has undergone. This is a case of polytrauma. Right distal femoral fracture comminuted and left tibial condyle bicondylar fracture has been operated about 10 months back. The right femur has been fixed with a supracondylar nail with additional plate by MIPO, and the left tibia has been operated with bicondylar plating without any problem. C1 type of fracture treated with supracondylar nailing. Immediate postoperative picture. AP and lateral pictures. This is follow-up picture subsequently. This was the simple multilock supracondylar nailing. The patient able to flex the knee and extend it comfortably at 1 week because of the keyhole surgery which has been done. Another lady with supracondylar fracture treated with multilock supracondylar nailing. This is at 1 year, the patient is having full function. Here you can see the bike compression screws which has got head from other side to lock the screws to achieve intercondylar compression. A floating knee segmental femur with tibia, again treated with one incision through the knee using supracondylar nailing. Another patient with x-rays at 3 months, very low supracondylar fracture. This was a demonstration case done by me during operative nailing course at Mumbai in SL Raja Fortis Hospital, Bandra, where this patient had a femoral prosthesis earlier, sustained supracondylar fracture due to osteoporosis. This was a demonstration case done treated with multi-lock supracondylar nail. This is a case treated earlier year in 2017 operative nailing course, operated by Dr. Amit Ajgaonkar. Again, he used multi-lock supracondylar nailing, and this is 1 year follow-up showing nice consolidation. This is the clinical picture of the same patient. This is a case shared by Dr. Jamin Washi from Gujarat. After attending the nailing course, he has used the supracondylar nail for a very badly comminuted supracondylar fracture of the distal femur. He was able to achieve good intra-articular restoration and also achieve bicondylar compression using the bicompression screws. This is the immediate post-operative picture in the patient. These are some follow-up pictures. The patient was put on CPM or continuous passive motion machine. This is at 3 months. This is at 11 months when the patient had good knee function with fracture consolidated around the nail so beautifully. This is the knee flexion. This is the knee extension and knee flexion at 11 months. This was a case operated by me about 1 year back. I have used supracondylar multilock nailing. This is the immediate post-operative X-ray in that patient. Came for follow-up only once at 3 months when these X-rays were taken. The patient was so comfortable right from day one, which you will see in the operative video, that the patient never came for follow-up. Even these December 2019 clinical pictures have been taken by sending one of our assistant to his home, and he refused to come to hospital to get an X-ray done. And the reason he says is, when I don't have any problem, why I want to get unnecessary X-ray done. Now we shall see the operative video of a multi-lock supracondylar nail for a supracondylar fracture of the femur. Hello everybody. Here is an elderly patient of 75 years with oblique supracondylar fracture of the distal femur, where we will be demonstrating a supracondylar nail which has got multiple locking option in the distal fragment. Here is the X-ray which shows long oblique supracondylar fracture with a small fragment which we will be fixing with a locking supracondylar nail. Friends, we are operating a oblique fracture of the supracondylar fracture of the femur. Thanks to Dr. Nitin Deshpande, President of Maharashtra Orthopaedic Association, who has taken the initiative to record all these videos and show all of you all the steps of the surgery. As this is an oblique fracture, I have kept a wire passer ready. If required, I will be passing the wire. Otherwise, I will be doing a supracondylar nailing with multi-lock system with this nail. This is a supracondylar fracture femur. We are operating on a simple table and doing a multi-lock intramedullary supracondylar nail. The patient is positioned on a simple table. At the end of the table, the leg is beyond the table by about 1 feet, and there is a triangular pillow below the knee, giving a small flexion of about 60 to 90 degree to the knee. And as the thigh is lifted slightly up, the C-arm also is positioned in an oblique fashion to get the AP of the distal part of the femur. This is the position for lateral view of the C-arm. The patient is positioned at the end of the table over a triangular pillow. This is the end of the simple table. You can see about a foot length. It's outside, so that I can flex the knee to about 60 to 90 degree. And this is the lateral view for the C-arm. And see, the IIT will go behind below the table for AP view. Intraoperative picture of the fracture site and the knee both in AP and lateral position. This is the inferior polar patella. at the inferior polar patella, I am taking a midline incision. I am hitting the bone and cutting vertically or splitting the patellar tendon in line with the incision. Now I am inserting the solapur sleeve or the protector sleeve, which is beveled on one side. The bevel end will look upwards so that it will protect the patellar tendon as well as the patella when I am doing the reaming subsequently. Through the solapur sleeve, I am introducing a guide pin which is slightly on the lateral condyle. It's about 5 mm on the lateral condyle from the notch. Please don't move. Shoot. अजून थोडे खाली.
तुमच्याकडे ना
Shoot. बस. Guide pin passed through the protector sleeve or the solapur sleeve. The entry site is not exactly in the center of the notch. It's about 5 to 7 mm more on the lateral condyle, as you can see here. In AP it is slightly on the lateral condyle, and in lateral it is at the anterior end of the Blumensack line. I am happy with that position of the guide pin, and I am advancing the guide pin parallel to the anterior cortex. So these are anterior cortex. I am advancing it parallel to that. Shoot. Save. In the lateral picture, it is at the anteriormost part of the Blumensack line, as you can see here. The guide pin is then advanced parallel to the lateral cortex in AP and parallel to the anterior cortex in lateral picture, as you can see in these Siam pictures. Now this is a 10 mm end cutter, which we normally call as cheese cutter, which I will pass over the guide pin and make a hole in the distal femur, which is 10 mm all around. Once the guide pin position is confirmed, the entry site is done with a cheese cutter or end cutting reamer, which is 10 mm in diameter, which is seen here passed over the guide pin. Now I will remove the guide pin and insert the plain guide wire through the same cheese cutter or the end cutter. Shoot. Save. Okay. Because the fracture is easily reduced in that position, without any problem, I am able to pass the guide wire into the proximal fragment, and I will just hammer this to get fixed in the trochanteric region. This work of this is over. Now we will ream the canal sequence. From the cannulated end cutter, the guide pin is removed and a flexible guide wire is inserted. The guide wire is advanced into the proximal fragment. With the straight cannulated reamer, I am reaming and sizing the canal. Easily this 10 mm is going. With stiff cannulated reamer, reaming is done. I have reamed with 11 mm reamer and it has gone almost up to the, as you can see, up to the lesser trochanter area. It has crossed the isthmus. So I am using a 11 mm nail. With stiff cannulated reamer over the guide wire, reaming is done up to the level which is required or beyond the isthmus if you are using a long PFN. Okay. Video चे wide angle असते. Yes. Now I am passing a 13 mm cannulated awl to make space for the expanded portion of the proximal part of the nail in the condyles. Now I will remove the Solapur sleeve, and the work of rotating the soft tissue is over. Now over this guide wire I will be inserting the nail which is selected. Nail we have selected which has got 2 mediolateral locking and 2 oblique locking. So this is the assembly which is assembled for the oblique locking, one from the medial aspect, one from the lateral aspect, and there are 2 holes here for lateromedial locking. So this we will be inserting now. This is how the distal engagement of the fragment will be there. As it is threaded, it will have good purchase and the rocking of the nail is prevented, because the distal part of the femur is bell shaped with a wide medullary canal. So in that metaphyseal area, to prevent the nail rocking medially laterally, so this oblique locking as well as the threaded locking bolts will help. So this is the lateromedial to locking, and this is anterolateral to posteromedial, and anteromedial to posterolateral to distal locking. Yes. Now I am passing the nail over the plain guide wire. The final few millimeters seating has to be done by firm blows. After reaming, the nail is advanced. Here the AP picture at the fracture site and the entry site on the right side. You can see the tip of the nail is buried subchondrally. Now I have finally seated the nail, which is about 4 or 5 millimeter from the subchondral bone. The junction of the nail and the jig can be seen on the C-arm. With that only I have confirmed. Now that I have confirmed, I am removing the guide wire and doing the distal locking. Proximal most of the lateromedial locking, that I will be doing first. Drill sleeve, hammer, counter support. Yeah, there is a bone. Shoot. Key there. I'll just reduce the length. Now that the drill bit is touching the opposite cortex from inside, now this is the length of the screw I have to use. So this is the length of the screw I have to use. The nail has threads inside for the locking bolt, and the locking bolt will get fixed and it won't rock. So I am selecting a 55 mm locking bolt, and I am passing over the hole. Counter support. Shoot. I am sounding with the guide wire, which confirms that my locking is within the nail. The distal locking is done with the help of the jig. Here you can see the drilling being carried out. After drilling, the selected screw is being passed. This bolt has got threads in the central portion or the shaft portion, which will catch into the threads corresponding within the nail. So the mediolateral movement of the nail will not happen in this type of fixation. This is the final seating of the first screw. Done the proximal most lateromedial locking. Then I am doing next the oblique locking, which are the next two. Then finally I will do the lateromedial distalmost locking. There are two oblique locking. The medial to posterior, anteromedial to posterolateral is more proximal than the anterolateral to posteromedial. So I'll do it the first this, next this one, and lastly the distalmost locking here. Happening afterwards. Hammer. Yeah, touching the bone. Drill. Chavi. Right. Okay. Right. This is the next screw I am using. 60. What? Yeah, 65. You give me 65. Yeah, fine. Okay. Artery focus. Yeah, okay. It is hitting the opposite cortex. Now I know that the length of this screw is also 65 millimeter. 65. This is the length of the screw which we are using. एकदम thread लावले की बंद करो साक्षी. Counter support. Doing the distal most lateromedial locking. Hammer. Hello. Cut. Remaining holes in the distal part of the nail being locked with oblique screws as well as an horizontal screw just above the entry site. lateral picture at the nail entry site showing well reduced fracture. I have applied the proximal locking jig, and as this is a 30 centimeter nail, I am making a stab incision with the help of the jig at 30 centimeter. I am using the proximal most or the dynamic hole hammer. Okay. Drill sleeve, drill, shoot, थोड़ा पुढे घ्या माझ्याकडे, shoot, 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 yeah, across the hole, shoot, save, shoot, shoot, save.
टाकून बघायचं
40 millimeter bolt for proximal dynamic locking. Shoot, 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 save. Proximal dynamic locking. On the left side is drilling and on the right side is passage of the bolt. Now I'll remove all the jigs. This is the lateral proximal locking jig, and this is for the lateromedial locking jig as well as for the attachment of the oblique locking jig. I had problem with the length of the screw, and also the screw was not going, the threaded screw was not going properly, so I had to remove one of the screw from here which was giving trouble, and I have used two screws which are slightly smaller in size from these two sides. But anyway, since they have got threads and holding the nail well, that shouldn't make any difference. Now finally we have to give thorough lavage to the knee, and over a drain we have to suture the wounds. Final wounds after the closure: the entry side transpatellar approach, the oblique locking and the lateromedial locking, and this is the drain. Normally I keep a drain in the knee joint for about 48 hours. This drain helps in preventing the knee stiffness. One of the commonest cause for knee stiffness following supracondylar nailing is the bone debris draining out from the bone into the knee joint, and if you keep a drain like this, the chances are reduced to a great extent. Thank you very much. Immediate post-operative X-ray showing a well fixed fracture. This is the case of supracondylar fracture which we had treated 2 days back with multi-lock supracondylar nail. Patient at present is doing ankle pump exercises, and we have done the dressing of the knee and also removed the drain today after 48 hours. This is the static quadriceps exercise he is doing. Now he will do the knee bending. गुडघे वाकवा, सरळ करा.
तो जास्त पाहिजे. Yes, sir.
सरळ उचला, सरळ करून उचला. Yes. Yes. So he is doing both knee bending as well as static quadriceps exercise and as well as active quadriceps exercises.
3 4 5 1 2 3 4 5
Now he is doing the knee bending
1 2 3 4 5
sitting by the side of the cot.
1 2 3 4 5 1 2 3 4 5
This is the 75-year-old person whom we are treated with supracondylar nailing, walking, partial to full weight bearing with the help of walker, comfortably at the end of 48 hours. Thank you. Friends, just now you have seen the operative video of this patient. This is the pre-operative and immediate post-operative picture. This is one of the follow-up picture. Patient came at 3 months in February for an X-ray and subsequently he has never come for follow-up. The clinical picture on the right with him sitting on a chair was taken at his home by one of our hospital staff. The patient refused to come to hospital to get an X-ray done, saying he is not having any problem. Why to unnecessarily get an X-ray done? You have already seen him so enthusiastically walking in the immediate post-operative period. So you will understand that this nail is very useful for such elderly patients. Without much pain, they can be mobilized. This is a prize catch. This is done by my friend Dr. Amit Ajgaonkar from Mumbai. This was a patient having intertrochanteric fracture with comminuted fracture of the femur with Hoffa fracture, all ipsilateral. We will not discuss about the other fracture this patient had. This right side femur was treated with intertrochanteric was treated with a sliding hip screw or the DHS. Then supracondylar nail was used to fix the fracture and the Hoffa element was fixed using a CC screw. You can see that the butterfly fragment has rotated outside and the same was derotated and additional bone graft was done at 3 weeks time. This is at 6 months when the patient already had good function of that right side femur. This is the X-ray at 18 months showing nice consolidation with good function of the knee joint as you can see in the video.
चालू करतो. हां कर. सरळ वरती घे. दुमड पाय. फ्लेक्स. व्हेरी गुड. स्ट्रेट कर. खाली कर सरळ. ओके. थँक्यू.
This was a case operated elsewhere, came to me after about 11 months, treated with open femoral nailing for intertrochanteric fracture with distal femoral fracture. Unfortunately, the distal femoral fracture X-rays were not taken properly earlier, and when I took the X-ray, a good valgus deformity could be noted, as well as the patient never had walked on this lower limb due to pain. Again, what I did was reamed the distal middle canal, saw that the nail could be jailed to one side by putting 2 polar screw anteroposteriorly, similarly 2 polar screw lateromedially, and did this supracondylar nailing, the regular supracondylar nailing with lateromedial locking, and added plate and bone graft at the non-union site. The number 1, 2 are lateromedial polar screws which are pushing the nail to anterior side, and number 3 and 4 are anteroposterior polar screw, which are pushing the nail to the outer part. So the nail was jailed to the anterolateral quadrant of the distal femur. This is just at 4 weeks. The patient had a reasonably good function and the patient was able to walk with a stick in opposite hand. This is at 9 months, showing nice consolidation. And these are the clinical picture. At 2 years, the, the patient able to walk comfortably without any support, squat and sit down unsupported. You can see the patient squatting and getting up unsupported. Ipsilateral fracture neck, fracture shaft and tibia fracture with non-union of the distal femur fracture, treated with intramedullary supracondylar nailing, bone grafting and wave plate. This function after implant removal. Okay, thank you. Squat and sit down unsupported. You can see the patient squatting and getting up unsupported. Another case, a canine femur was done for a distal femoral fracture. Patient had a valgus deformity. I did a supracondylar osteotomy and fixed that with a supracondylar nail, and the patient had a good correction and good function. Another case, this is an example of extreme usefulness of supracondylar nailing. My friend Dr. Milind Chaudhary, an elizero expert from India, from Akola in Maharashtra. This patient had a valgus deformity of the left lower limb with also shortening. You can see the X-ray on which all the angles have been mapped. Here, the supracondylar nail with polar blocking screws have been advantageously used to do an osteotomy, and with a uniplanar distractor, fracture has been distracted to get the alignment correct. As you can see, the black line is passing through the Fujisawa point or the lateral tibial spine eminence, indicating that the alignment is 100%. Lengthening was also carried out to get back the limb length equality, and this is the clinical picture after the fixator. Everything has been removed and the patient had an excellent function. Coming to some of the tips for supracondylar nailing. One should do it at the end of the table with a small bolster or a triangular pillow under the knee joint. That will reduce the fracture automatically and this recurvatum deformity will become less. The surgeon should be able to flex the knee from 60 degree to 120 degree so that entry properly from the distal femur can be done. C-arm should be positioned in such a way that good AP and lateral picture of the knee can be taken, especially while passing the guide pin. If you are operating a C2, C3 type of, it's better to drape the opposite limb also sterile in this fashion, so that this is the AP position being taken. When we take the lateral picture, instead of moving the limb which has got lot of comminuted bone pieces, you can lift up the sterile non-involved limb to get a good lateral picture. If the fracture is comminuted, then you have to use a open method. For uncomminuted or plain supracondylar fractures, A or B type or even C1 type, one can get away with a keyhole incision. The entry site. Entry site is just in front of the notch, slightly on the lateral condyle. You can see that white line in the middle picture. It's slightly toward the lateral condyle. It has to be parallel to the lateral cortex of the femur, and your entry direction should be parallel to the anterior cortex, and this entry is done at the anterior part of the epiphyseal remnant of the Blumensaat's line. Here you can see beautifully the Blumensaat line. At the junction of articular portion with the Blumensaat line, the guide pin is passed. A simple intertrochanteric with supracondylar fracture. A comminuted supracondylar fracture treated with the supracondylar nail. The patient was advised bone grafting as he had a compound fracture initially and it was treated little late. But the patient never came for, and when he came after about 3 years, the fracture had consolidated, and this is the function. If there is an intra-articular extension, always try to fix with a CC screw either anteriorly or posteriorly so that it will not come in the way of the nail. Convert the intra-articular fracture into plain supracondylar fracture by this CC screw. Always pass the guide pin in the center of the distal fragment both in AP and lateral. Then only try to open that with the reamer. Never look at the proximal fragment and try to pass the guide pin into the proximal fragment. Always look only at the distal fragment or the small fragment. Let your guide pin be in the center both in AP as well as in lateral picture. If there is comminution, it's better to allow collapse at the supracondylar region. We have got good lengthening mechanisms available. If it is required, it can be done later. A badly comminuted fracture, you can see beautifully collapse has been done, and the alignment is more important. The proximal and distal fragment are well aligned. That is more important than getting the length back. Always keep a drain within the knee joint, because since you have done the reaming through the knee joint, there are bone debris, hematoma gets drained into the knee joint. If a drain is not kept, there are many chances of non-inflammatory swelling, non-infective swelling of the knee joint, which is very troublesome. So to avoid that, it's always better to keep a drain within the knee joint for about 48 hours. Always keep the knee in a knee frame with at least 90-degree knee flexion. Otherwise, if the patient keeps the leg extended, getting back the knee flexion will be difficult later on. So if the knee is kept flexed, getting extension as well as further flexion will be much more easier. If there is intra-articular comminution like C2 or C3 type of fractures, take a parapatellar approach and identify all the fragments, fix them temporarily with KYs, and then do the nailing. At the end, you can fix all these fragments with. This is an example of open reduction of all the fragment to get beautiful anatomical restoration. Another example of a fractured femur with comminuted distal fracture of the tibia, femur as well as upper part of the tibia. Again, you can see open reduction has been done. All the fragments have been put around the nail without causing any condylar splaying, and this is the picture at 13 months showing nice consolidation. This case, you can see that the nail has been very proud at the entry site, and a very short nail also has been used. So because of the patient had a non-union with resorption of the bone all around at the fracture site. How we can avoid complications? The commonest complication is inserting the nail from the intra-articular fracture site causing condylar splaying. Second one is keeping the nail proud at the entry site. And third one is trying to enter into the proximal canal causing deformity of the distal femur, either valgus or varus deformity. Majority of the time it is varus deformity. This condylar splaying or widening of the condyle can be prevented by fixing the intra-articular element with CC screw. As in this case, you can see that they have been passed posteriorly without coming in the way of subsequent nailing. This supracondylar fracture with the Austin Moore prosthesis above was treated with a supracondylar nail long time back. The patient came with distal radial fracture. The clinical picture was taken, which are excellent. So this varus is due to guide wire not being positioned properly in the center of the distal canal, and the surgeon, that was me, trying to get the nail into the proximal canal in a hurry. So always keep your guide wire in the center of the distal fragment in AP, parallel to the anterior cortex in the lateral picture. Always look at the distal fragment only. Let it be in the center of the distal fragment. Never try to enter and get the close reduction into the proximal fragment. Here the nail has got a small bend which has to be kept anteriorly to match with the procurvatum of the femur, but unfortunately the surgeon has kept it in the reverse fashion, causing recurvatum deformity. In this case, the nail is proud within the knee joint. The patient had good clinical function without this nail troubling, but this should be avoided. This can be avoided by seeing the tip of the nail before final seating, and also the jig has got a small hole through which you can pass a K-wire and find out the level at which the tip of the nail is present. The best way I still feel is remove the conical bolt by few threads and see the gap between the nail and the jig. That's the best way to confirm that the nail is well seated at least 5 mm inside the subchondral bone. As I said earlier, very bad comminuted fractures don't tolerate distraction to get back the length. Allow collapse. Here you can see fracture has been collapsed beautifully, but maintain the alignment. Once you maintain the alignment, the bone will heal around the nail properly. If the collapse is too much, we can think of lengthening the tibia or lengthening at a later date. This was a case done by me only, where I had kept the fracture distracted in the femur. I had to go back and redo the surgery in the immediate post-operative period to get the fracture reduced properly and to reduce the distraction. Friends, finally, few good indications for supracondylar nailing are double fracture like segmental fracture of the femur, fracture shaft femur with condylar fracture of the femur, fracture neck femur with fracture shaft femur, where you can use two different implants. For the neck, the sliding hip screw, and for the shaft, you can use supracondylar nail. This is after consolidation in the same patient. Floating knee injury, you can use supracondylar nail both for femur as well as tibia. If there is an implant either in the hip or the knee, here there is a hip prosthesis, supracondylar nail can be done for distal femoral fracture. Majority of the knee prosthesis have got space in the notch to push in a supracondylar nail. So a fracture, periprosthetic fracture with the knee implant can be also treated with a supracondylar nail. Finally, the take-home message. What is important for a good result is perfect reduction of the joint surface, correct alignment, solid undisturbed stability till the fracture unites, and early return to function. Friends, plan is yours, setup is yours, you are the boss in your setup. So I have given my ways of treating these fractures with a supracondylar nailing, as it is a very versatile implant. Definitely it is coming back after seeing the bad results of locking plate, but definitely it's a technique which everyone should have in their armamentarium for a right indication. Thank you. Friends, just now you have seen the multi-lock supracondylar nailing video as well as large series of cases treated with supracondylar nailing over the past 2 decades by me. If you have any doubt, you can write to me on my email, which can be seen now scrolling down. Thank you for watching the video.